All right, we'll go ahead and get started. Again, good afternoon, and thanks for joining us today. Welcome to the Mycosis Study Group Education and Research Consortium Grand Rounds Webinar Series, episode number 2, entitled Cryptococcosis, Updated Management Strategies. I'm John Baddley from the University of Maryland, and really happy to have on my team today Jeremey Walker from the University of Alabama, Birmingham, and David Boulware from the University of Minnesota. Today will be a case-based discussion of cryptococcosis and updated management strategies, and it'll also focus a little bit on COVID-associated cryptococcosis. So it's important that we keep this interactive, and I think it'll be better for the group. And so please, if you have any questions, enter them in the chat function or the question and answer function. We have several spaces throughout the slides in which we can discuss the cases, etc. All right, we'll get started. Jeremey? All right, case 1. Now, this is a 50-year-old male who presented to the hospital with weight loss, headache, and nausea and vomiting that was progressive over approximately 2 weeks. It was a frontal headache and really worsened over the past 2 or 3 days, and so prompted him to come to the emergency room. He had no fever, chills, or visual changes associated with the headache. Past medical history, he tested positive for HIV in 2013 as a workup for lymphadenopathy, but did not seek treatment and was unsure if it was a real test. And so really he has been without care for a number of years. 2 weeks prior to the presentation that we're speaking about above, he was diagnosed with thrush at an urgent care facility. So his social history, he lives in Birmingham, Alabama. He's originally from Zambia and has been in the States for about 15 years, visits Zambia regularly. Last sexual activity was with a female partner several years ago. No previous sexually transmitted infections. Next slide. So if you look at the physical exam, really was fairly unremarkable, except the gentleman was thin, and on examination of his mouth and throat, he had evidence of white plaques. As far as the laboratory studies in the top left part of the screen, you can see in red in that corner slot, the creatinine is 1.5 or slightly elevated. He also had a hemoglobin of 10.3. His CD4 count was 1, and his HIV viral load, again, was 166,000 copies, and he had not been on therapy. As far as a CT scan of the head, it was performed in the ED and really was unremarkable, did not see any abnormalities, and he underwent a lumbar puncture. The opening pressure of the lumbar puncture was normal at 15 centimeters of water. The glucose and protein were also normal. And the white blood cell count was completely normal as well, with 0 cells, the range being 0 to 5, and no red blood cells. However, he had a CSF cryptococcal antigen that was abnormal at 1 to 320, and the serum cryptococcal antigen was also abnormal at 1 to 1280. Gram stain showed 3+ yeast, and the CSF culture and also his blood cultures that were drawn in the ED were positive for Cryptococcus neoformans. Next slide. So just a brief overview of typical induction therapies that are recommended for cryptococcosis. And of course, they are the WHO guidelines, there's the IDSI guidelines, and the DHHS guidelines, among others that we typically use. These are reflective of the DHHS guidelines that were last approved, I believe, in January of 2021. I'm sorry, July of 2021, and just listed here as options by the grade from the document. So number 1, amphotericin B preparations with either lipid or regular, plus flucytosine is a preferred therapy, followed also by amphotericin B preparations plus fluconazole, amphotericin B preparations alone, the alternative of amphotericin B plus flucytosine shortened approximately 7 days, followed by fluconazole, which is really in line with the WHO recommendation. Fluconazole plus flucytosine and fluconazole alone. So at our disposal, we had all those options to treat this patient. Next slide. So now a polling question, Tom. How would the group on the call manage this patient? Amphotericin B, time 14 days plus flucytosine. Amphotericin B for 7 days plus flucytosine. Single dose liposomal amphotericin B at 10 mg per kg plus 5-flucytosine, or fluconazole plus flucytosine. So please give us an answer. All right, thanks, Tom. So it looks like the favorite for this particular patient was amphotericin B for 14 days plus flucytosine. About almost 60% of the attendees have chosen that, but interestingly, there are a quite nice mix of others. 30% actually with single dose liposomal amphotericin B, which is quite interesting, and we'll have to discuss that later, David. All right, we can move on and close that, please. Thanks, Tom. All right, so the clinical course for this patient, he received induction with lipid amphotericin B plus flucytosine, and the plan was for 14 days, which is fairly standard at our institutions. However, amphotericin B was discontinued at day 7 due to kidney injury. As I mentioned earlier, he had a creatinine of 1.5 on admission, and now it had climbed to 2.5. He had a repeat lumbar puncture at day 7. The CSF was no growth. He completed a 14-day course of flucytosine, 7 days of amphotericin B, and then fluconazole at an equivalent dose of 1,200 milligrams was added for the second week to complete the 14-day induction. So he actually did quite well. Follow-up 3 weeks after diagnosis in the clinic was done, and he had the fluconazole dose was decreased to 400 milligrams. His creatinine was really back to baseline, not quite normal. He was started on antiretroviral therapy and then followed several times after that, and actually had done quite well. No evidence of immune reconstitution, and his actually viral load came down quite nicely, and CD4 rose quite slowly. But anyway, he's doing well. Before we move on, I just want to open it up for discussion for the attendees. Any questions or comments about the particular case or how the patient was treated?
Feel free to type out questions in the Q&A window there.
So just a couple of interesting facts about this case. Just looking at the laboratory studies, the white blood cell count was normal, glucose was normal, and protein was normal. Again, certainly we expect to see normal white blood cell counts in people without with advanced HIV, but I guess I was a little surprised that those were normal. In addition, his opening pressure was completely normal, which is, I would say, in the minority of these kind of cases that I have seen. So I was a little surprised by that as well.
It looks like one of the questions in the chat is, with that normal opening pressure, do you normally repeat the lumbar puncture in these patients? I guess in this case, he did have the cryptococcal culture that was positive as well.
Yeah, so I mean, I always, at least at week 1 or 2, would get a repeat lumbar puncture to see clearance of, sterility of the CSF. And certainly if their pressure was elevated, I do another tap sooner, either a day or 2 after the initial, to make sure that the pressure is decreasing or corrected. I don't know if you want to comment on that, David or Jeremy.
Yeah, in our cohorts in Uganda, we basically use scheduled LPs where everyone gets a follow-up LP on day 3, day 7, and day 14. And what we've shown previously was published, I think in 2014, was that if you got an LP in the first week, regardless of your baseline opening pressure, there was a survival benefit. And so the overall benefit was, I think, a 69% reduction in 10-day mortality over the first 10 days. We also have follow-up data that shows that if you get 2 LPs in the first week, so one basically on day 3, one on day 7, that there's a mortality benefit beyond day 7. So censoring everyone that dies before day 7, that of those who survive at least through 7 days, there's a longer-term benefit of doing therapeutic LPs in the first week. And I'll put the reference in the chat window for the prior Rolfes publication in CID.
Great question. We'll move on to another question that's certainly a good one. And I wondered myself after seeing the case, is it common practice to start antiretroviral therapy at 3 weeks? And I would say in my personal practice, this is earlier than I typically started. I tend to go more at the 4 to 6 week range myself. Not exactly sure about this particular situation and why it was 3 and not 4 to 6, but that's what I typically do based on the literature. Any comments, Jeremy?
No, I agree. I think this was an example of just reporting the case as it actually occurred. And I think it was just the timing of their follow-up appointment that ended up being closer to the 3-week range than 4 weeks. They were doing really well. And so they arranged and went ahead and started therapy at that time. I'm not certain. I think that it was mainly potentially around a holiday or some other factor and when they could actually get into clinic and see the provider. And with that slightly early start, it seemed like everything still did well. But I completely agree. The typical practice and the recommendations are the 4 to 6 week time frame.
Right. And another question: what in your experience is the proportion of patients who have to stop amphotericin B due to toxicity before the end of week 2? I guess we can all give our individual sort of thoughts, but my practice typically is cancer and transplant now, and so I see a lot of patients who cannot tolerate a full 14 days of amphotericin B, really whether it be lipid or traditional. And again, we really move with lipid, but many of these renal transplant patients already have renal insufficiency, and it's challenging to get even 7 days of amphotericin B product in them sometimes. And again, neutropenia, anemia, those kind of things. And so I think, I would love to go 14 days in everybody, but it's not realistic in my current practice. Dave or Jeremy?
I mean, I think as Dr. Masa Abbasi put in the chat window that, with the active trial results, the Malloy New England Journal paper, that when you look at the antifungal activity of 7 days versus 14 days, the antifungal activity is the same in CSF. The rate of clearance is the same. CSF sterility is the same at 2 weeks. And so amphotericin has a really long half-life in tissue. And so we've looked at it in brain tissue weeks or months later, and you can still detect amphotericin. So based on the active trial results, I think that if you run into toxicity, like in this case, and you have to stop at 7 days, that's probably adequate therapy. Certainly, there are cases, I hear about of, patients, being sent into renal failure and being dialyzed while they get their amphotericin. I think that's causing more harm than good.
If there are no other questions now, I think Dave will move ahead to some new options for therapy, perhaps.
Yeah, so for those that have not been living under a rock, you may have noticed at the end of March there was a small trial that came out in a small journal in Boston, and it was led by Joe Jarvis, and it was a multinational trial. It was basically the Ambition trial. This was single-dose liposomal ampho for crypto. Next slide. And so this was a landmark trial for many different reasons. Among one is the largest cryptococcal trial that's ever been conducted. And so just to review what they actually studied. And so the 2 regimens that were studied, one was basically a single dose of liposomal ampho. So this was Gilead branded Ambisome. It was given at 10 milligrams per kilo on day 1. And then participants also got oral 5-FC in divided doses, and they got fluconazole, typically also in divided doses. And so the 5-FC and fluconazole were run over 14 days, and then after 2 weeks, the fluconazole was stepped down to 800 milligrams through 10 weeks, and then thereafter 200 milligrams of secondary prophylaxis. The control arm is basically the WHO standard of care from 2018, which is 1 week of IV deoxycholate with flucytosine. And so this was in the active trial, as I mentioned before, which had basically the same rate of fungal clearance and actually had better outcomes than 2 weeks of IV amphotericin, likely due to decreased toxicity. After 1 week, they were switched to high-dose fluconazole, and then at 2 weeks, 800 milligrams of fluconazole onwards. Next slide. So the overall results of the trial, you can see the Kaplan-Meier curve there on the left, and on the right, basically what the absolute risk reduction was between the single-dose liposomal ampho versus the control regimen. And you can see in basically the intention to treat analysis that the overall this was viewed as non-inferior, and so the non-inferiority margin was set at 10%, and so that's the dashed line on the right. And overall, the trend was favorable towards the liposomal ampho group. And when you adjust it, and when they did the adjusted analysis, so the intended to treat population, but adjusted for altered status and baseline ART status and CD4 and GCS and anemia, a number of sort of risk factors that were pre-specified in the statistical analysis plan. All the factors sort of associated with cryptococcal mortality. In the overall trial, they were fairly equally distributed, but some slight differences between groups. And so when you adjust it for that, overall it was superiority towards the liposomal ampho group. The absolute difference was 5.7%, and so 5%, that's pretty. That's a noticeable difference in mortality. The overall sort of mortality. Next slide was in the intervention group was a little bit under 25% versus 28.7% in the control group, and so fairly similar mortality. When you look at other sort of endpoints in the trial, the rate of fungal clearance was basically the same. So when you look at sort of this early fungicidal activity of the rate of clearance, it was 0.4 log 10 CFUs per milliliter per day. So basically, you can do quantitative cultures and plate out and see how many yeasts are alive in the CSF, and you can look at that rate of clearance over time. And so it's a direct measure of the antifungal activity. And so it was basically 0.4 in the liposomal arm, and it was 0.42 in the control arm. And so this is basically the same, was not statistically different. And generally from our prior studies, once the clearance rate is above 0.2, that's generally associated with pretty good outcomes. Conversely, if you look at sort of fluconazole monotherapy, at 400 milligrams, it's fungistatic where there's no clearance. At 800 milligrams, you're getting like 0.08 log CFU per milliliter per day, and so sort of very low levels of clearance associated with much higher mortality. And so the EFA is a direct measure of the antifungal activity of the regimen. There certainly can be many reasons why people die with advanced AIDS, but as far as the antifungal activity, it was very similar. If you look at the number of grade 3 and 4 clinical adverse events, the toxicity was less in the liposomal ampho group. And so a number of these are HIV related or cryptococcal related, not surprising. And so in our COAT trial, this is actually probably a little bit lower. In our COAT trial, which was the ART timing trial that we published back in 2014, our rate of AEs through 1 year was about 80%, had some grade 3 or 4 adverse event through 1 year. And so in the first 21 days, this is about as expected. Next slide. So when we talk about AEs, so adverse events, there's obviously a lot of sort of known sort of toxicities. But in the control group, what was the most common laboratory adverse event associated with giving 1 week of IV amphotericin deoxycholate? Was it anemia? Was it acute kidney injury? Was it hypokalemia, or was it neutropenia? So there's many toxicities of amphotericin, as we all know. Some are more serious than others. So we'll see what the audience says. So overall, while the creatinine rose in the control group, the average sort of rise in creatinine was about a 50% relative increase in creatinine value. The actual most common adverse event was actually anemia. And so so amphotericin suppresses your erythropoietin production, and in the control group, with just 1 week of amphotericin plus 5-FC, the rates of anemia were 40%. And about 18% of people had to get receive blood transfusions during that time period. In contrast with the single-dose liposomal ampho group, that was only 13%. And so, not everyone on the call today is a hematologist, and so beyond the hematologists that might really care about this, anemia is actually quite important because it's it's related to the oxygen carrying capacity to the brain, and so if you're not perfusing your brain, that's ultimately a bad thing. And so by anemia, that certainly in prior cohorts has been a risk factor for mortality in Cryptococcus. Next slide. And so one question are the ambition data relevant to case number 1? So the case number 1 is presented, which was a gentleman originally from Zambia, oddly enough, who was living in Alabama. And so do people find that the ambition trial results are informative for the case number 1 patient? So you say yes, it is potentially informative. That doesn't mean you necessarily have to do it, but there could be reasons why you think it might not be. And so I'm kind of curious what the audience thinks. Is the 814 person trial too small? Is the median CD4 count of 26 too high and not relevant to U.S. patients that we might see. Was the trial not conducted in the Northern Hemisphere? And so, or was there some other reason why you might not think the trial would be relevant to U.S. patients? Okay, so we have a lot of people that say yes, but okay, so I think that I think this is kind of, it's an interesting, it doesn't necessarily mean that everyone needs to adopt this as standard care, as practice, but my personal sort of opinion is that it is very potentially relevant to U.S. patients. Ultimately these trials are looking at antifungal regimens, and so there, as I mentioned, there may be many reasons to die, but this early fungicidal activity, this EFA, is really a quantitative metric of what's the rate of fungal clearance, what's the antifungal activity of the regimen. In this case, it's very similar, and so there's not a difference. In the AMBITION trial, they did not see relapse cases occurring, so it wasn't as if the fungal counts went down with just a single dose and then they rebounded and relapsed. And so in the experimental arm with the liposomal ampho, 0 of the 400 patients had relapse within the first 10 weeks. So I think that's kind of nice to know. So, and then from a purely geographic perspective, so those that have worked in Uganda realize that Kampala technically is in the Northern Hemisphere. It's above the equator, and so there were a number of patients that were enrolled. Actually, about 40% of the patients were enrolled in Uganda, and so there were some Northern Hemisphere data. Next slide.
So we'll move into case number 2, and I think can continue to put in questions in the chat. We're getting into management and transplant, which is a little bit more complex and not as much data to guide us, and we'll kind of reference some of that. So certainly recognize not everyone on this call are transplant providers necessarily, but have all seen Cryptococcus in a variety of forms. And so we'll have several polling questions as well throughout, and I just encourage you with each topic to go ahead and start putting things in the chat, and we'll pause at the end again of this case to have a broader discussion. So this case is a 62-year-old gentleman with a history of heart transplant in 2012, who you're actually currently seeing on stable tacrolimus and sirolimus. But before we get into why you're seeing him today, let's talk a little bit about his history, because he actually has a history with cryptococcal meningitis. So in 2013, he presented with signs and symptoms of meningitis and actually received induction therapy with lipid amphotericin and flucytosine. He received 2 weeks of therapy and did well. His main complication was ongoing issues with increased intracranial pressure. And it was to the point where he was even able to transition to the outpatient stage, but was still requiring visits for LPs every few days, and eventually ended up receiving a VP shunt at the 6-week mark. That actually was complicated by a coagulative staph infection 2 months later and was removed. And by that point had no more issues with his intracranial pressure. So it had been removed by this point, but was something that was required for a period. He underwent 18 months of fluconazole, did really well in his outpatient follow-ups as far as symptom resolution. And in 2015, he was doing well, and the decision was made to stop his fluconazole therapy. He, at the time, they weren't necessarily trending cryptococcal antigen as a means of guiding that, but the most recent serum cryptoantigen he had, which was near the end of therapy, was 1:640, as shown there. So this will open up to kind of our first question as we're going through. So the guidelines that we have that we'll look at in just a minute do suggest maintenance fluconazole can be discontinued at 12 months for SOT recipients. And this is a challenging question because I know you're thinking about all of these pieces, but to put you on the spot, what factor would you consider most important in your decision to end therapy? And so serum cryptoantigen trend, disease manifestations at diagnosis, do they present with meningitis or disseminated disease versus pulmonary only? How their immunosuppression is doing, were you able to decrease, or are you having reasons to increase? Follow-up imaging or clinical findings that you're following as you go throughout that year, or I rarely stop maintenance fluconazole therapy in solid organ transplant. So we'll give a few seconds for response. Okay, so it looks like here many people are, the most common response is immune suppression trend, which I think makes a lot of sense. The concerns around, especially if there's any reasons that you're having to increase immunosuppression, you wouldn't be taking that into consideration in your thought of discontinuing therapy. I think the other question would be, does there need to be a decrease, or is stability okay? And that would be an interesting thing to discuss. I guess the next kind of tied for second is the serum cryptoantigen trend, as well as follow-up imaging and clinical findings. So really following how they're doing over time. And I think that is another question of discussion, is how important is the cryptoantigen versus just watching the findings. And we actually discussed this a bit in the Southeastern Transplant ID group. And it was really interesting to hear perspectives from various providers that care for those patients. The consensus, at least from that group, was a bit of emphasis on follow-up imaging and clinical findings over necessarily the cryptoantigen trend from the serum. And then a couple, or a vote each, or a couple votes for the disease manifestations, and a couple that rarely stop maintenance fluconazole and SOT. And again, I've already seen some stuff in the chat, so that's perfect. And we'll come back and kind of address everything together. This is our guidelines for management of cryptococcal meningitis in solid organ transplant from Dr. Baddley and Dr. Forrest, who put these together for us. This is really, and they kind of acknowledge, based off extrapolating data from other populations primarily. So we don't have a robust data set that specifically looks at this population, but in general, the preferred therapy is liposomal amphotericin for a minimum of 2 weeks combined with 5-FC. And then there are options for alternative therapy if needed, and even extending duration. And then, of course, going to consolidation and maintenance. And the big question that we kind of brought up was around when to discontinue. And so the minimum is 6 to 12 months, but they acknowledge in the paper, and just as we discussed, there's a lot of things that you may consider at that 12-month point, and a lot of reasons to push and continue for a much longer period of time. And then pulmonary disease that you can treat with fluconazole only, but the importance of making sure it's limited to pulmonary disease and further evaluating that. So the next question, that's just kind of an interesting one, is that we just learned about ambition, I think quite compelling data that we have. And so are there some situations where you might extrapolate ambition protocol for solid organ transplant recipient? I think Dr. Baddley already mentioned the complexities of treating some of our renal transplant patients in particular with a prolonged course of AmBisome. So what do you think? Would you consider ambition protocol for this patient, or a renal transplant patient potentially? Ooh, interesting. So it's about 2/3, 1/3. 2/3 said yes, they would, and a third said no, they would not. I'm looking forward to hearing a bit about that as we get to this case. I think that's a really interesting question. Okay, I'll keep moving through those so we can hear the rest of this story. So the reason you're actually seeing this patient currently, a reminder, this is a heart transplant from about a decade ago now, who's on stable tacrolimus and sirolimus. And in January, they actually had mild upper respiratory symptoms. They were diagnosed with COVID. At the time, they were actually managed as an outpatient with just supportive care. They weren't on steroids, and no steroids were provided. They did well. About a month later, they actually developed a new headache. They went into an outside hospital. At the time, the serum cryptoantigen was unchanged at 1 to 640, so unchanged from the last known value we had. They did a lumbar puncture, which had 12 white counts, so it was elevated white blood cell count, all lymphocytes. The RBC was normal, protein and opening pressure were all documented as normal. We actually didn't have the exact values. We just had a report of normal. The CSF cryptoantigen was not reported, and so unclear if it was done or what that value was. There was a CSF culture which we were able to follow up on to confirm that was negative. And at the time, it was actually attributed to post-viral or COVID syndrome. And this leads us to a question. Of course, the thing that everyone is concerned about is potential relapse of cryptococcal meningitis. And so my question for the group and all these providers, many who care for this population, is, have you seen a relapse of cryptococcal meningitis years after completing therapy? And so answer choices are never, rarely, but in cases where there's been a clear precipitating event, maybe surrounding immune suppression or some of the other things that we discussed earlier, rarely, but when it happens, I can never attribute it to any specific cause. I've seen it regularly, which I would say is at least once every few years, or I can't remember a case, but but I'm not actually caring for this SOT population regularly. And so a pretty good mixture of responses, it looks like. About a third say never. Have they seen a relapse this far out? Another third or so say rarely, but with a clear precipitating event. And then the rest are distributed between. It looks like about 10% have actually would say that they see this on a fairly regular basis, which is interesting to comment on as well. So we'll move forward. So a couple months have passed. And now it's April, and those headaches had actually continued. And so presented back this time to our institution and had a repeat lumbar puncture. And so I have the comparisons so that you can see. So in our lumbar puncture at April, we see first the serum cryptococcal antigen has increased threefold now. So we're up to 1 to 2560. The CT head is again normal. So they do the LP. This time they find an elevated opening pressure, 45. Increase in the white count now to 45, elevated RBCs. The glucose and protein were both normal, but now we have a CSF cryptococcal antigen of 1 to 5120. And if you had any debate at all, we have also blood cultures and CSF cultures that are all growing Cryptococcus neoformans, and the blood or the CSF cultures actually persisted through a week of therapy. So clearly a case of cryptococcal relapse. And so given that and what we just discussed, and as far as a clear precipitating event, do you think COVID-19 contributed to the patient's recurrence? And just as a reminder, this patient remained outpatient. They had no directed treatments, including no steroids provided. So it was truly just a mild case of COVID managed with supportive care and unstable tacrolimus and sirolimus. So your options are highly unlikely through highly likely. And I gave you even the option of just saying, I really don't know. I'm going to go in the 50-50 camp. So you got everything in between. Interesting. So it looks like most people are kind of saying in the middle between unlikely and highly, or unlikely and likely. A quarter took the 50-50 option. And it looks like about a third in the unlikely camp, and then about 45% that would say it's likely or highly likely. So a little, just to address a couple of other management considerations in solid organ transplant, and then I think it'll be interesting to really get us into the discussion timeframe, because I'm interested to see what you all are thinking. There are some additional complications to think about in solid organ transplant, some that kind of overlap with our HIV population. One of the issues, of course, is elevated intracranial pressure, which is true for anyone, but something that is a particular concern, and we kind of saw illustrated in this case. Another a unique entity is immune reconstitution syndrome, something that at least we see it in multiple different arenas within Cryptococcus, but wondering if there's certain risk factors or things to identify. There actually was a really great CID article from 2015 from Dr. Sana looking at some risk factors for immune reconstitution syndrome in the solid organ transplant patients in particular, and really the presence of CNS disease and discontinuation of calcineurin inhibitors seem to be the strongest kind of precipitating risk factors, but it's an important entity to recognize. And then there's all the other complications that we can see in general population as well, such as cerebral vascular events, again, associated with Cryptococcus. So for this particular patient, they actually completed 2 weeks of induction therapy of lipid amphotericin and flucytosine. They were transitioned to oral fluconazole. They were actually on a fairly low dose immune suppression that had been stable for a long time, but they were able to decrease the TACR goal slightly and to as they could to help. A VP shunt again was actually required. This time was done inpatient at the 2-week mark. And this time it's actually done well. And so no further complications with infections at that site. And he is doing really well, actually. He's asymptomatic now. And he's actually at 13 months follow-up at this point in time. So another interesting question would be, would anyone consider stopping therapy in him? And what would be needed for you to get to that point? But with that, I think that brings us to the end of this case. So I'm gonna stop sharing and kind of open it up for discussion and the things that are in the chat.
Yeah, so Jeremy, just a question. What would you do after 13 months of fluconazole if the patient is tolerating fluconazole? Would you stop? Would you keep going?
There are a lot of people on this chat that I would want to talk to before I considered stopping therapy. And so that is definitely not something I would feel comfortable doing at this moment. But I think I would be interested to hear what some of the experts in the room would think about that question.
I think, Jeremy, I would not call myself an expert with transplant patients, but I think you've identified a challenge that we really don't know. Like, what's the rate of relapse? Is this a 1% phenomenon? I think there's obviously a lot of individual factors on what's the ongoing immunosuppression versus at time of their original presentation, and so it is complicated. And you kind of, I think most physicians look at a gestalt of many different factors. Even though Craig titers don't predict sort of outcome, we still sort of tend to measure them because if it's negative, it makes you feel good. Or if the titer has gone down substantially, it makes you feel good. And if you stop your secondary prophylaxis and something happens and you recheck it and the titers increase, then your sphincter tone goes up dramatically.
Jeremy, just a question. Do we know whether it's a relapse or reinfection?
That is a wonderful question. We don't have the original isolate to be able to sequence and to be able to confirm. The patient hadn't had any change in activities or anything that would put him at particular new risk other than just living in Alabama where there's a lot of crypto. And so certainly I suppose the capacity to, I think in the chat, it was mentioned in some other studies that it generally is thought to be the original isolate, like in resequencing when looked back. But this is a pretty far timeline. I mean, it was 2013 was the original case, and 2021 was the new event. And so I'm not certain. I'd be interested into your thoughts, Dr. Perfect.
Well, I was interested in this too. So I actually went back and looked at our cases. So we now have about a dozen cases that relapsed after a year, including one of them at 21 years. So we've got those isolates. And so we're going to actually sequence them to see. My suspicion is they're the same, but I'm not certain about that. And so we just need to be careful when we say, well, was it really a relapse isolate that stayed in the body all that time, or these people are more susceptible in general, maybe some genetic susceptibility on top of this, and they're constantly being exposed, had COVID, et cetera, et cetera. So I think you're right that this is relapse, but I'm not certain. And hopefully we can get a little more idea of this because again, well, I didn't realize it when we went back and looked at it. We have over a dozen patients that have relapsed after a year. And these are not just AIDS patients. These are all different types. We need to look at it.
So just to add to that, so Pete and I and others did a study of our UAB cohort a couple of years ago. We had followed about 120 solid organ transplant patients who were treated for cryptococcosis, whether it be pulmonary, disseminated meningitis, et cetera. And our practice had been over the last decade to stop fluconazole after about a year and watch them. And of that cohort, we had one who possibly relapsed. And I guess the median follow-up was about 5 years. Now, this case you presented is actually in our cohort, so I'll have to add that to 2. But I think the important thing is, we have shorter term data that suggests relapse is lower. And again, that's sort of how they helped us inform the guidelines. But it's interesting that John points that out, because I think, it's hard to establish large cohorts and follow them and report these data. And we may not really know the truth,
Yeah, John, I wouldn't say we have a lot. We have very few. I mean, this is 500, 600, 700 patients, and I've got maybe a dozen. But we just want to go through the long-termers. And again, to see to make sure it's relapse versus reinfection and stuff like that. So I don't know the answer yet. They're being sequenced as we talk about.
In our HIV population in Uganda, when we went back to during the COAT trial back 2010 and 2012, our rate of relapse through 1 year was about 5%. And generally those people had virologic failure and they had fluconazole resistant yeast. And so 2 things have changed since then. One was that, at that time we were using sort of 400 milligram doses during consolidation of fluconazole. And so when you step up the fluconazole to higher doses to 800 milligrams, we just see sort of less relapse overall, and just making sure people aren't having virologic failure.
Any other questions regarding some of the other components we covered in SOT? One of the things that I guess came up that I saw a couple mentions of in the chat, I'd be interested, Dr. Baddley, as far as your approach to the kind of serum cryptococcal antigen, and maybe some others in the chat as well, but I'll start there.
So, we keep saying that serum cryptococcal antigen monitoring is not helpful. And that's great, but I don't think there's a cohort that has actually looked at it carefully. I mean, we tried to do it and we just didn't have enough people, and people stopped tracking serum cryptococcal antigens far out because we think they don't work, right? So, I mean, you definitely don't have data to support it, but I'm not sure there might be some value, but again, I think we can't answer that question. So, I don't put a lot of stock in it either. I mean, like David said, if the number is lower, I feel better. If the number is high, similar to when we diagnosed them with cryptococcal meningitis a year prior to that, I feel a little bit more nervous about stopping things. But again, I don't put a whole lot of stock in it because I've seen so many patients who have persistent antigens for years and years and years and are successful after stopping fluconazole.
Yeah, I mean, I think the best data came from Judy Aberg's study that was published in 2000, and that was from WashU sort of cohorts, and I think that most of that was from the pre-ART era, and so what does that mean today is unclear. But certainly short term, like, I'm going to check a cryptococcal antigen a month later or 2 months later is not useful, and certainly serial monitoring in CSF is not useful either. A good question in the chat is, so what do people think of the ambition regimen towards solid organ transplants or non-HIV populations? So this is, I think, a great question. There's not a clear answer, and there's going to be a distinct difference of opinion. So John and Jeremy, do you want to kind of chime in on your thoughts?
Go ahead, Jeremy. I'll chime in after you.
You keep putting me on the spot for the hard ones. I mean, I think that the reasoning behind the shorter course that you described is compelling. And I think that my experience has been that although there have been several instances where we've had to stop, especially earlier than the typical 2-week course that we generally do because of kidney injury. And so specifically for the renal transplant population, which tends to actually present later, at least my understanding in the data is they maybe a little bit later post-transplant in that 12 to 18 month time frame. Their immune suppression is a bit more stable, not as high traditionally as some of the other like lung, heart, et cetera. I think that would be a particular group to consider this in, especially for those that are presenting we actually had a patient recently that we saw on service that we didn't do the ambition protocol, but we did kind of intentionally stop at a week, not because of complications, but just because they were doing so well. And so I think in a carefully selected population, certainly, but I'm really interested to hear the rest of the room's thoughts.
So, I mean, my thoughts is, we've derived all our solid organ transplant cryptococcosis treatment data from HIV studies, correct? And so why not derive it from this new study? So I'm actually excited about this new trial and application to solid organ transplant patients because the devastation of renal failure in these patients. I mean, as Dave mentioned earlier, dialysis, losing your kidney. I mean, it is terrible. And I think, I'm excited about this shorter course. I really am. And I'm going to try it the next patient I see.
Yeah, I think when you look at the toxicity in the Ambition trial, only like 5 or 6% of people develop sort of grade 3 or grade 4 renal insufficiency. That's pretty severe sort of renal insufficiency. But if you look at the relative creatinine increase, as I mentioned, it's basically 50% with 1 week of amphotericin deoxycholate. With the single dose, there was a 20% relative increase in creatinine with the single dose liposome LAMPho. So there just was and that was at day 7. Sorry. So the change in creatinine value through day 7, 50% sort of relative increase versus 20% relative increase, suggesting that it's relatively non-toxic to kidneys. And so that being said, the median age in this cohort, I think, was 35, 40 years of age. And so this is kind of a relatively younger cohort, has pretty good kidney function at baseline. And so but still, that relative difference in increase kind of suggests that, hey, there's probably going to be less, nephrotoxicity with a one-time single dose therapy. And when you look at the antifungal activity, which is ultimately kind of what an antifungal drug does, it was the same. And so, I think it's something to think about. And obviously not every, you have to think about it, and every patient is a little different and weigh the risks and benefits. But it's something I think to consider.
Can I make a statement on my opinion? I think what this study did was show that you can get some pollen into the patient pretty quickly and pretty high and can get some positive results. But I also want everybody to be really careful of that study, and that fact fluconazole and flucytosine were also players in this game. We talk a lot about pollens because we worry about nephrotoxicity and all the other things. But be very careful doing just a high dose ambisone early short course, and then throw away the flucytosine or go on to the fluconazole. Be very, very careful. That flucytosine is an underappreciated drug in this regimen. So that's a warning, I think, of this thing is stay along, that this might be able to give these things to patients earlier with high pollen exposure, reducing it, et cetera, but don't give away the flucytosine and the fluconazole.
Yeah, I think that's a very good point. And, clearly 5-FC is renally cleared, and so you would need to renally adjust that if you have renal insufficiency at start. There was a phase 2 trial with the Ambition that was before the phase 3 trial. That was also published in CID a number of years ago, also by Jarvis. And in that, they didn't have access to 5-FC, so it just was a fluconazole backbone, and it was compared to a fluconazole backbone in the control group. They also had fairly good results, similar rates of clearance. And so if you can't use 5-FC for some reason, it's a possibility. But the best data certainly comes from the use of 5-FC with fluconazole in the phase 3 trial.
I think we have time for one more question that's in the chat that I just wanted to bring up. I guess in some ways it comes into this, but what if you have lack of sterilization of the CSF at day 7 or day 14? Does that change anything, especially if you're using a shorter course duration, or would you continue with the protocol?
So in the original Vanderhorst trial in 1997, the ACTG trial that was published in New England Journal, if you were not sterile at 2 weeks, that was associated with higher risk of mortality at 10 weeks. And so the caveat with that is that that was with 400 milligrams of fluconazole. And so what we found when we looked in 2000, I think it was 14, we published this data, also by Rolfes, was that with 800 milligrams of fluconazole using a higher consolidation dose, that if you're culture positive at 2 weeks, that was not associated with 10-week and longer mortality. And so I think the key thing is making sure you're using a higher dose of fluconazole until you know that the CSF culture is definitely sterile. And so generally, we always make sure that the CSF is sterile. And so if they're still culture positive at 2 weeks, when they come back for their next visit, we'll re-LP them and make sure at 4 weeks or 6 weeks or whenever, we'll keep re-LPing them to make sure that they are sterile. Because if they still have ongoing sort of CSF culture positivity, or do they have a resistant isolate to fluconazole? Do you need to alter your therapy or give intermittent doses of amphotericin to make sure they're sterilized?
And just one comment, I think we all on the call believe that repeating an LP is important, but again, it's not always done at 2 weeks if the patient's feeling better. We've seen plenty of times where the patients are just sent out and changed therapy without knowing about CSF sterilization. So again, it's important to do that in my opinion.
Yeah, and in the Ambition trial, everyone was hospitalized for at least 7 days, and the protocol was everyone got an LP at 7 days, and even if they were discharged, after 7 days, they came back for an outpatient clinic visit at 14 days and got a repeat LP at day 14. And so I think that's still, you can't just be like, oh, it's one dose and we're going to send them out and send them home, follow up in a month with your primary care doctor. That's still not the recommended care of a crypto patient.
I think we're going to share, just to briefly share some of the cryptococcal data. So I'll go ahead and pull that up. There are a couple of good questions, it looks like, in the chat as well, that potentially we can work on responding to as we're going through this. And then we should still have a couple more minutes at the end, because this will be brief. I wanted to begin by just thanking this community, because truly this study was done because of this community. And this is what we wanted to present, is very much just preliminary. This is non-reviewed and truly just initial demographics of the data we were able to collect. But what we essentially did was create a survey to try to just capture the experience of post-COVID or post-SARS-CoV-2 crypto. And so the case definition was a new diagnosis of cryptococcal disease within 90 days of a diagnosis of SARS-CoV-2. And so that was released. Really, the MSGERC was incredibly helpful in amplifying that, as did and coordinating that. And the CDC Emerging Infection Network also helped us expand our reach. We had 70 cases submitted by 30 separate investigators, many of whom are on this call. And so just greatly appreciate you participating in that. And of course, Dr. Pappas in helping mentor me through this process. And so this is, again, just the preliminary demographics we felt comfortable we could share that had, were clear. We still have some logistic regression, other things to explore in this data, and even a few of things that we collected that we need to clean up and clarify with some of our investigators. But what we have seen in the 70 is a median age of 61, and male predominance, which kind of correlates to some degree with severe SARS-CoV-2. Our collection was primarily within the US. You can see the breakdown there. The 3 international entries, 2 were from Nigeria and 1 from India. Immune compromising condition, actually 47% had no severe traditional immune compromising condition. The largest proportion of immune compromise was our solid organ transplant patients, followed by malignancy, and those on chronic immune suppression. Of the 5 HIV positive patients, only 1 of them was on medication and biologically controlled. There was a good amount of diabetes as a comorbidity, which multiple studies have kind of reported as an additional comorbidity and concern in cryptococcal disease. And then we have outlined the chronic those that were on chronic immunosuppressant, which was about 40%. About a quarter were on multiple agents. That aligns nicely with our solid organ transplant group. And you can see the breakdown of the type of agents that are on there, again, primarily driven by our solid organ transplant group. As far as the COVID diagnostics, or the time of diagnosis, most were from 2021, which just makes sense based on the collection period and when we saw some of our biggest peaks and waves. And then the COVID treatment you see is somewhat varied. There were about a fifth that actually received only supportive care. And then you have a large portion that received immune suppressants, which should be a surrogate of hypoxia, at least based off of how those are assigned. And then about half or a little over half that received an antiviral, a little under a quarter that received plasma or a monoclonal antibody. And some of that is just based off what was available, especially for those early cases. And then this is really the meat. What was the outcomes that we saw as far as Cryptococcus and the timing? So we saw that actually the duration of symptoms was not particularly prolonged. This has been compared. One of the worries was because of the overlap in symptoms with SARS-CoV-2. Could we see what we saw in our case of kind of a misalignment? And really, there was only an 8-day median duration between cryptococcal symptoms developing and a diagnosis. You see the interquartile range there. And it was actually pretty close to there's diagnosis of SARS-CoV-2. So the median amount of days between SARS-CoV-2 diagnosis and cryptococcal diagnosis was 22 days. And again, you can see the interquartile range there. And then you can see the symptoms of Cryptococcus that was reported. Again, lots of variation and overlap, honestly, with SARS-CoV-2, and a little. I think the one notable comparative to other studies is potentially a little bit more respiratory symptoms than is typical, and that is probably related to that SARS-CoV-2 component. And then we looked at how was cryptococcal disease confirmed, and one of the things is not just what all of these things weren't necessarily done in all of our patients. So we wanted to actually report how many actually had the diagnostic test performed, and then what was the overall positive rate for the cohort. So that's why it's written out like this. One of the reasons is that 11 of these cases were actually diagnosed post-mortem based off a culture result that came, from the patient return with, severe illness, and the culture result came back after the patient had already deceased, so they weren't able to perform the remaining of the test. But what we see is that about 60% had a positive serum cryptoantigen, about 3/4 had that done, almost half had positive blood culture, so a pretty high amount of cryptococcemia, sepsis from this group. And then also a pretty high amount of CSF or meningitis, with 20% of the cohort showing evidence of that by cryptoantigen. And there were 16 patients that were diagnosed by other culture. All of those were respiratory cultures, actually, and you can see what the respiratory source was. And none of those actually were positive by serum or other, but we haven't had the chance to go back and really tease out, are some of these patients those that were diagnosed or confirmed post-mortem, and that was the reason. So that is some of the additional analysis that stands to be done. But probably the thing that stood out to everyone and the most concerning piece here is the mortality, which is much higher than we would expect for a population primarily in the US, and likely reflects the severe SARS-CoV-2 component added to this. But about 60% almost mortality, which is quite high. So with that, I'll stop sharing. I think we're coming up on the hour, but can address any questions.
Just wanted to thank all the attendees today for joining us for the MSGERC webinar. We want to thank Jeremey, of course, and David Boulware, as well as Tom, Lisa, and also John Perfect. And just to also finally thank the CDC. This webinar was sponsored in part by a CDC cooperative agreement with University of Alabama, Birmingham, the MSGERC, and Terra Nova. So thanks again, and we look forward to future webinars. Important to note that this will be recorded and available on the MSGERC website. So if you missed part of this today, then please catch it on the webinar, on the recording.